Today, we are reporting from the 2020 ASCO Scientific Program. We are recapping some of the top news that are being presented during the conference, and soon we'll speak with Dr. Melissa Johnson on some of the practice-changing lung cancer data being presented, Dr. Malin Javel on some pivotal gastrointestinal cancer abstracts, and Dr. Hope Rugo on the biggest studies in breast cancer. Welcome to OncLive News Network. I'm Gina Columbus. An analysis of data collected in the COVID-19 and Cancer Consortium Registry showed that patients with progressive cancer were 5.2 times more likely to die within 30 days of being diagnosed with novel coronavirus 19 compared with patients in remission or with no evidence of disease. Additional updates from the Global TerraVault Consortium Registry show that chemotherapy administered within 3 months of a diagnosis of COVID-19 increased the risk of death in patients with thoracic cancer. In the phase 3 Boston trial, initial results showed that the triplet of selinexor, bortezomib, and dexamethasone significantly improved progression-free survival and objective response rate compared with twice-weekly bortezomib and dexamethasone. Rates of peripheral neuropathy were significantly reduced with numerically fewer deaths on the selinexor arm versus the doublet in patients with multiple myeloma who have previously received 1 to 3 lines of therapy. In an interim analysis of the phase 3 Keynote 177 trial, pembrolizumab doubled progression-free survival versus chemotherapy in patients with newly diagnosed microsatellite instability high or mismatch repair deficient metastatic colorectal cancer. At a median follow-up of 32.4 months, the median PFS was 16.5 months with pembrolizumab versus 8.2 months with standard chemotherapy with or without bevacizumab or cetuximab in patients with MSI-high dMMR mCRC, leading to a 40% reduction in the risk of disease progression or death. Adding avelumab to best supportive care improved median overall survival by over 7 months in patients with locally advanced or metastatic urothelial carcinoma in the phase 3 Javelin Bladder 100 study. The results showed that the addition of the PD-L1 inhibitor reduced the risk of death by 31%. In lung cancer, adjuvant treatment with osimertinib demonstrated an 83% reduction in the risk of disease recurrence or death in patients with stage 2 to 3A EGFR mutant non-small cell lung cancer in an interim analysis of the phase 3 ADAURA trial. Additionally, in patients with stage 1B to 3A disease, which was the overall study population, osimertinib demonstrated a 79% reduction in the risk of disease recurrence or death. In patients with relapsed refractory classical Hodgkin lymphoma, pembrolizumab was superior to brentuximab vedotin and demonstrated a statistically significant and clinically meaningful improvement in progression-free survival across all subgroups in the phase 3 Keynote 204 trial. The data suggests that the PD-1 inhibitor should be the standard of care for this patient population. In the phase 2 TROPHIMUNE trial, gestational trophoblastic tumors that resist chemotherapy can be treated with frontline avelumab, making the PD-L1 inhibitor the first immunotherapy to show efficacy in treating patients with GTT. In the INFORM registry, results show that the feasibility of implementing a large-scale, multinational, personalized oncology platform to aid in decision-making and improve clinical benefit. INFORM also provided diagnostic refinement and targeted therapy options for pediatric patients. Hello, everyone. We are here with Dr. Melissa Johnson, who is the Associate Director of Lung Cancer Research at Sarah Cannon Research Institute. Hi, Dr. Johnson. Thank you so much for being here with us today. And it's so nice to be able to sit down with you, even though it's virtual. How are you doing?
Hey, Gina. Nice to see you again. Happy ASCO. Glad to be here.
Happy ASCO indeed. So today I would really love to have you shed some light on the really fantastic lung cancer data that's coming out of this year's meeting. Let's start with the phase 2 CITYSCAPE study. So we're getting a lot of buzz around the anti-TIGIT antibody tiragolumab, which is being looked at in combination with atezolizumab versus placebo and atezolizumab as frontline therapy for patients with PD-L1 positive non-small cell lung cancer. So what are your thoughts on this trial and the significance of the data?
Well, I'm glad to hear there's a lot of buzz about it. I also think this is a cool trial. It's evaluating tiragolumab, as you said, which is an anti-TIGIT antibody. TIGIT is an inhibitory checkpoint. It works like PD-L1. It's immune cells like T cells and natural killer cells. And when TIGIT is blocked with the anti-TIGIT antibody tiragolumab, it restores the T to recognize the tumor, anti-PD-L1 antibody atezolizumab. So in Cityscape, patients were randomized to receive tiragolumab and atezolizumab versus placebo and atezolizumab, as you said. Patients were newly diagnosed with non-small cell lung cancer. They lacked EGFR and ALK rearrangements, and all patients had to have tumor tissue that expressed PD-L1 at a level of 1% or higher as assayed using the DACO22C3 assay, either locally or centrally. The primary endpoints were objective response rate and PFS. So the primary endpoints showed that the addition of tiragolumab to atezolizumab improved objective response rate as well as PFS over placebo and atezolizumab. Now, when the patients were evaluated just based on their PD-L1 score, and patients with high levels of PD-L1 were treated with the combination, likewise, they did even better with the combination of tiragolumab and atezolizumab versus placebo. And this was in terms of response rate, 66% versus 24%, as well as PFS with a hazard ratio of 0.3 in those patients with high levels of PD-L1. So as we come away from ASCO 2020, it appears that we have a new immune combination that we could use for patients with perhaps higher levels of PD-L1. This is being assessed in a confirmatory randomized phase 3 trial, tir and atezo versus atezo.
Thank you so much. It sounds like a really, really exciting trial. Congratulations.
Thank you.
Sure. So you're also authored on the first in-human study of CX-2029, which is a pro-body drug conjugate targeting CD71 in patients with advanced cancer. Could you discuss this trial as well?
Yeah, sure. So this was the first in-human phase 1 experience of CX-2029. As you said, this is a pro-body conjugate, and it's directed against CD71, which is a transferrin receptor. And so it's expressed on both malignant as well as healthy cells where there's a lot of iron turnover, where the cells are rapidly dividing and growing. So the trick about targeting CD71 is that we want to target it on the tumor tissue, but not on normal cells like erythrocyte precursors, red blood cell precursors that also express CD71 in high levels. So the pro-body drug conjugate is super important. It is a masked antibody. The mask prevents the CD71 from binding to the transferrin receptor in healthy tissue. But in the tumor microenvironment where there's a lot of proteases, that chews up the mask and exposes the CD71 to its receptor, and so it can bind in the cancer cells. So this trial was the first time that this drug was put into humans. It was well tolerated. Not surprisingly, the most common side effect that we saw was anemia. Seemed to be dose dependent, and probably in part due to the mechanism of action of the drug, as well as the fact that the payload is MMAE, which is associated with cytopenias like anemia. Perhaps the most exciting results of this trial were the 3 partial responses that we had: 2 patients with non-small cell lung cancer and 1 patient with a head and neck squamous cancer. In fact, it was squamous cancers throughout the trial that seemed to have some of the best responses. And so going forward into expansion, the dose selected was 3 milligrams per kilogram, and we'll be exploring it in squamous non-small cell lung cancer, head and neck, GEJ, and gastric cancers, as well as lymphomas. So this was an exciting trial to be on the ground floor of, and hopefully at ASCO's to come, I'll be telling you more about it.
That's great. I'm looking forward to hearing more about it too. Thank you so much. Now let's turn over to some longer term follow-up that we're seeing now with the Checkmate 227 trial, which is of course looking at the combination of nivolumab and ipilimumab for the first line treatment of patients with metastatic non-small cell lung cancer, for patients without EGFR or ALK genomic tumor aberrations and whose tumors express a PD-L1 level of 1% or higher. So what do you think that these longer findings of follow-up tell us?
Yeah, I think they confirm what we've already seen in many immune therapy and immune combinations that have been previously published, that the benefit of immune therapy without chemotherapy is truly in the tail of the curve. It is that small percentage of patients that are alive now at 3 years after treatment with a relatively small number of doses of nivolumab and ipilimumab that have allowed patients to do so very well. I think this year is interesting at ASCO that we had right before ASCO the FDA approval of nivolumab and ipilimumab for patients with newly diagnosed non-small cell lung cancer expressing PD-L1 at 1% and higher. We had atezolizumab also approved for patients expressing high levels of PD-L1. And then just this week, nivolumab, ipilimumab, and chemotherapy, a la the 9LA data that we'll also hear about during the oral abstract session. And so the frontline space for non-small cell lung cancer is changing so rapidly. It's a little hard to see through the tea leaves today at the beginning of this meeting exactly what that will mean. The chatter at ASCO is also something that we are all missing this year, and I think I'll be looking at Twitter. We're having a watching party here at Sarah Cannon, and we'll start to make some decisions about what this means for our patients together over the next few days.
Absolutely. Now, you also brought up the Checkmate 9LA trial, and like you said, we just saw that most recent approval with nivolumab and ipilimumab plus chemotherapy for frontline non-small cell lung cancer. So could you shed a light a little bit more on this trial and the importance of those data?
I think it also, once again, affirms what we intuitively know, that chemo and immune therapy is probably the best treatment for many of our patients with newly diagnosed lung cancer. And so this is Opdivo and nivolumab and ipilimumab's chance to be combined with chemotherapy. And it does answer, for me, the question of how much chemotherapy do you really need? Patients in this trial got less than the 4 doses that some of the keynote studies showed. And so it does seem like we need the chemotherapy to control the cancer initially while the anti-immune response is getting revved up. But maybe you don't need a whole lot. So I think that we'll see now some experimentation perhaps with the amount of chemotherapy that's added to immune therapy. But I think the take-home lesson is that the two together are probably the state of the art.
Those are some great points. Thank you. Now, I'd really love to focus on an agent getting a lot of attention lately as well, trastuzumab deruxtecan. In the Destiny Lung 01 trial, the agent was explored in patients with HER2-mutated metastatic non-small cell lung cancer. What do you think is the importance of this type of trial and these findings as well?
I think the importance of this Destiny trial there are 2 things that we'll take away. First of all, yet again, we have another small molecular subset of lung cancer patients that can be identified that benefit from a targeted agent. And this is the story that we've seen played out so many times over the last 10 or so years. In particular, we've got a new RET inhibitor approved, a new MET inhibitor approved, just showing the importance of identifying these molecularly driven subsets of cancer. I think the other important takeaway from this trial is sort of an introduction to this new type of drug in non-small cell lung cancer, which is an antibody drug conjugate. We've been using it, for example, in breast cancer for a long time, but this antibody drug conjugate directed against HER2 with a payload that inserts itself right into the cancer cells is a relatively new idea in non-small cell lung cancer. I think there probably are a lot of other drugs coming that work in the same way. And because all patients without a molecular driver will get chemoimmunotherapy frontline, I predict that the place for antibody drug conjugates for most of our patients is going to be in that second line setting. And there are a lot of antibody drug conjugates being developed by Daiichi Sankyo, who developed this 8201 compound, as well as many other companies. So I think this is just the beginning.
That's wonderful. Thank you so much. Now, I do want to move into early stage disease, and a lot of people are also talking about the ADORA trial at this year's meeting, looking at osimertinib as an adjuvant treatment in patients with stage 1B to 3A EGFR mutant positive non-small cell lung cancer after complete tumor resection. What do you think that these adjuvant data mean for the field?
Yeah, well, as the planner of the plenary, I was so excited to include this abstract. Not for the reasons that you think. I am a lung cancer investigator, and so selfishly, I wanted a lung cancer abstract in the plenary. But I do think this is also showing a major shift for non-small cell lung cancer, following in some ways in the heels of breast cancer, where Herceptin was approved in the adjuvant setting after its coming out party at ASCO 10 years ago. So here too, we're starting to see the move of targeted therapies into the adjuvant space, not to mention the neoadjuvant space that's coming. This is exciting for me because it shows the fact that we now have really good drugs in lung cancer that are helping cure patients instead of just helping contain their metastatic disease.
Absolutely. Now, I want to be able to leave some time at the end here to talk about any other lung cancer research that you're authored on that you'd like to highlight. You're also chairing the plenary this year, the COVID-19 session this year. There's a lot that you're involved in. What else would you like to spotlight?
I do just want to mention a couple of the clinical science symposia. You know, these run unopposed at ASCO so that everybody can come. But to be honest, that seems to be the time where people find time to meet or to network. And so this year's ASCO allows the opportunity for us all to watch the clinical science symposium. There's one about the drug development for the rare cancer. And it's important because it is highlighting, once again, some tiny little molecular subsets in some small patient populations. But if you take a close look at the participants, the discussants in that session, you'll find we have a representative from pharma biotech joining the group. There's a representative from the FDA providing a regulator's perspective, as well as a patient advocate, an oncologist, as well as a patient himself. And so that to me is one of the best examples in this ASCO 2020 of Skip Burris's theme, Unite and Conquer, accelerating progress together. We as academic oncologists, community oncologists, we're used to coming together and we're used to being the voice of a meeting like ASCO, but clearly all of the stakeholders that I mentioned are important. And so I'm really proud of the essence of that session, and I hope you all have a chance to watch it. And then a final session I'll mention is harnessing immunotherapy with novel approaches beyond checkpoint inhibitors. This is also, as a phase 1 doctor, right from my heart, some of the drugs and modalities, immune effector cell therapies that I spend my time thinking about have made their way finally into the clinical arena with phase 2 data suggesting efficacy. We'll discuss a vaccine, we'll discuss immune effector cell, and a bispecific. And I think 5 years from now, that'll be the bulk of the oral sessions. So get a jump on it now and get a forecast for the future in that CSS.
That's so great. Dr. Johnson, thank you so much. You shared so much wonderful insight here today, and I hope you have a wonderful rest of your ASCO meeting. Thank you again for being here.
Thanks, Gina. Thanks so much.
All right, well, we are here with Dr. Milind Javle, who is the professor in the Department of Gastrointestinal Medical Oncology in the Division of Cancer Medicine at the University of Texas MD Anderson Cancer Center, to discuss some of the fantastic gastrointestinal cancer research that's being presented during the 2020 ASCO Virtual Scientific Program. Hi, Dr. Javle, how are you? It's so nice to see you and work with you today.
Thank you. Very nice to be here.
So, obviously, it is the 2020 ASCO Virtual Scientific Program, a little bit different this year since we are all virtual. But I would love to know, what are some of your thoughts on the gastrointestinal cancer research that's being presented this year?
Well, it's been a very exciting year in terms of gastrointestinal oncology and clinical research. Of course, it is a big regret that we cannot meet in person and interact with our colleagues from around the world. But there have been tremendous advances, both in upper and lower gastrointestinal cancers, specifically with targeted therapy, with immunotherapy. New inroads are being made on various fronts in these difficult to treat cancers. So I'm particularly excited in this field.
That's wonderful. Thank you so much. So something else I'd really love to discuss with you is the retrospective analysis of post-second-line chemotherapy treatment outcomes for patients with advanced or metastatic cholangiocarcinoma and FGFR2 fusions. You're the lead author of this study, and I would love to hear your thoughts on it and why the findings are so important.
So FGFR targeting is a very exciting field in cholangiocarcinoma. Unfortunately, a minority of patients, 15%, with intrahepatic cholangiocarcinoma have FGFR fusions. So this is a small segment of a uncommon or rare disease. So therefore, it's hard to do a randomized phase 3 trial. So you have to rely on retrospective outcomes. So we looked at patients treated on the 2204 pivotal study with infigratinib for cholangiocarcinoma patients with FGFR fusions. When the study was last presented at ESMO, 71 patients were treated and data was reviewed. We looked at the outcomes of patients who had received third or subsequent lines of chemotherapy and looked at how these patients did when they received second-line chemotherapy. So there were specifically about 37 patients who received standard of care chemotherapy such as FOLFOX or gemcitabine-based combinations, and then compared these same patients when they received infigratinib on third or subsequent lines. So the outcome of the patients with second-line chemotherapy was pretty similar to what you see with standard chemotherapy outcomes with FOLFOX, with FGFR2 wild-type cases. So the progression-free survival was about 4 months, response rates were about 5%. So this is very similar to data from the ABC06 trial. In contrast, patients who received infigratinib, or the same patients who received infigratinib in the third-line setting, they had a much better outcome with a response rate of about 21% and a progression-free survival of six months. So it's an indirect comparison, but it suggests that second-line chemotherapy is definitely no better than infigratinib, and probably infigratinib in this setting is superior and should be considered in the second-line setting.
That's great. Thank you so much for sharing that insight. I'd love to pick your brain a little bit more about infigratinib. Could you discuss maybe some of the data we've seen with it before? And obviously it's exciting that it already has a fast track status in the first-line setting.
That's right. This is a very exciting field in oncology, and specifically for cholangiocarcinoma. We are very fortunate to have pemigatinib approved a few weeks ago, and we hope the same fate for infigratinib. So infigratinib was, now there are over almost 120 patients treated with this drug. But the data, the mature data were presented at ESMO last year for 71 patients. The response rate, confirmed and unconfirmed, was 27%. And most patients had received two or more lines of therapy. In fact, 60% had received either 2 or 3 lines of therapy, and only 30% of patients enrolled in the trial had received 1 first-line therapy. So it was a very heavily pretreated population. We noticed that the disease control rate was 83% in this trial, which is an enormous figure for this disease, which is otherwise fatal. The duration of response was 5.4 months. The progression-free survival was 6 months. These are exciting results. There were, however, some toxicities. There's class effect of these drugs, such as hyperphosphatemia. It can cause some chelosis, stomatitis, hand-foot syndrome. So these are a very rare occurrence of retinal detachment or ocular toxicity. So in general, these effects are much more favorable as compared with systemic chemotherapy. And we hope that these agents are going to change the trajectory of this otherwise dismal disease.
That's great. Thank you so much for sharing this. Now, moving away from cholangiocarcinoma, the phase 3 KEYNOTE-177 trial comparing pembrolizumab to standard therapy as first-line treatment for select patients with advanced colorectal cancer is also a study with a lot of data that's got a lot of discussion and buzz around it the last day and a half or so. Could you discuss these findings and the significance of them?
So the KEYNOTE-177 study is a very exciting phase 3 trial, which is a part of the plenary session or the virtual discussion session now at ASCO. And there has been, as you know, single-arm data, non-randomized, of pembrolizumab for MSI-high colorectal and other cancers. and there's a disease agnostic approval for pembrolizumab with MSI high. So there has been, however, absence of randomized clinical data where pembrolizumab was compared with standard of care chemotherapy. So Keynote 177 looked at that. This phase 3 trial enrolled about 300 odd patients with metastatic colorectal cancer who had MSI high to either pembrolizumab or standard of care chemotherapy. In the study, it was noted that the progression-free survival was twice as high, in fact, 16 months versus 8 months with pembrolizumab as compared with chemotherapy with a hazard ratio of 0.6. There was also an improvement in response rate of 44% versus 33% with pembrolizumab as compared with chemotherapy. Now, a lot of patients who were on the chemotherapy alone arm subsequently probably got pembrolizumab. So the overall survival may not be that different in the two arms. But this study provides really level 1 evidence in the form of a phase 3 trial showing that pembrolizumab is superior to chemotherapy in MSI high colorectal cancer.
Wonderful. Those are some great points. Thank you. Now, also in colorectal cancer, but also in gastric cancer too, we're seeing some excitement with trastuzumab deruxtecan for the HER2 mutated disease types. Could you also discuss these two Destiny trials and how this agent could transform both paradigms?
Certainly. So HER2 new targeted gastric cancer, targeting of gastric cancer has been investigated widely now for, I would say, almost 10 years. HER2 new targeting for colorectal cancer is relatively recent. It is a rare population of colorectal cancer, but just given the magnitude of or the number of cases that of colorectal cancer that are unfortunately prevalent, there's still a significant number of patients with HER2 new amplified colorectal cancer. So several agents are being investigated. These include monoclonal antibodies, and in this specific instance, these are antibody drug conjugates. So this is a drug with trastuzumab and deruxtecan, manufactured by Daiichi Pharmaceuticals. And this was a phase study. This is the one that I'd like to discuss, colorectal cancer, because data in this disease are relatively novel in terms of HER2 targeting. 78 patients enrolled, 45% response rate with duration of response, which is still immature, 4.2 plus the higher level of confidence interval is not yet reached. Progression-free survival of 6+ months. And what is very interesting, Gina, is that these patients were heavily pretreated, and some of these patients had received HER2-directed agents before. So clearly, this is a path forward in terms of antibody-drug conjugate, and we hope that novel agents such as these will be now available to patients relatively soon outside of a clinical trial.
Absolutely. Thank you. Thank you. Now, you're also the lead author on the Treetop trial, which is a randomized phase 2 study of the efficacy and safety of varlitinib plus capecitabine versus placebo in second-line advanced or metastatic biliary tract cancer. So although we knew that the trial was negative, could you discuss still the importance of these findings?
So the Treetop trial built upon the experience of prior investigations for biliary tract cancer. There have been trials combining chemotherapy with EGFR targeted agents, and these trials have generally been negative so far. There is no EGFR targeted agent that is approved in combination with systemic chemotherapy at this time. Treetop trial included a slightly different agent, varlitinib, and this is the pan-HER inhibitor, which also includes HER2 and HER3 targeting in addition to HER1. So this was a second-line trial where patients with biliary tract cancer had received prior gemcitabine-based chemotherapy, and then were randomized to either capecitabine with varlitinib or capecitabine with placebo. So overall, I mentioned in this randomized phase 2 trial, there did not seem to be any improvement in the primary endpoint of the trial, which is progression-free survival between the study arm and the treatment arm. However, there were some interesting signals in that although the study was not stratified for different types of biliary tract cancer, patients who had gallbladder cancer, particularly patients with female gender, had a better outcome with an improvement in PFS as compared with those who received capecitabine with placebo. And these were similar, these findings were similar to a parallel study done in China called the J3 trial, which also found a favorable outcome in gallbladder patients with varolitinib. So we hope that HER2 targeting may have more value for that disease, that segment of biliary tract cancer, gallbladder cancer. So I think, although the study, as you said, was negative, there were important lessons.
Absolutely. Thanks so much for sharing that insight. And then just in conclusion, is there any other gastrointestinal cancer abstracts or anything else that you're authored on that you would like to highlight today?
Well, I'm just going to briefly mention some developments, for instance, in pancreas cancer. It has always been a matter of debate whether neoadjuvant therapy is a preferred modality prior to surgery, or patients with resectable pancreas cancer should directly go to surgery followed by adjuvant therapy. So there was the SPAC trial, the SPAC-5 trial from the United Kingdom, which looked at 3 different arms of basically neoadjuvant chemotherapy: gemcitabine, capecitabine, FOLFIRINOX, chemoradiation, all done prior to surgery versus upfront surgery followed by adjuvant chemotherapy. Now, this showed that the overall survival was significantly improved with neoadjuvant chemotherapy. So this, although this was a randomized phase 2 trial, not a phase 3 trial, hopefully it will put that matter to rest, that neoadjuvant chemotherapy is certainly perhaps a preferred option for resectable pancreas cancer. Along those lines, there's been also a neoadjuvant therapy from SWOG, the S1515 trial, which looked at 2 arms of 2 different chemotherapy regimens, gemcitabine, Abraxane, or FOLFIRINOX, before surgical resection. And they found basically that at least in terms of survival, both arms are relatively similar. So both options are probably reasonable to consider in the neoadjuvant setting. There were some caveats that favored gemcitabine and Abraxane, but overall, there was no significant difference.
Dr. Javale, thank you so much for being here with us today and taking some time out of the still very busy ASCO schedule, even though it's virtual this year. So I appreciate all of this really wonderful insight on the gastrointestinal cancer research being presented this year. Thank you.
Thank you very much. Appreciate your kind invitation.
Hi, so we are here with Dr. Hope Rugo, who is a professor of medicine and director of breast oncology and clinical trials education at the University of California, San Francisco Helen Diller Family Comprehensive Cancer Center. Dr. Rugo is going to be speaking with us on some of the really practice-changing breast cancer data being presented at this year's ASCO meeting. Hi, Dr. Rugo. How are you doing? It's so nice to see you.
Nice to see you too. Thanks for having me.
Of course. So obviously there are a ton of breast cancer data being presented at the 2020 ASCO Virtual Scientific Program. But first, I'd really love to look into the trial that you are the lead author of, the BYLieve trial with alpelisib plus fulvestrant in patients with PIK3CA mutated hormone receptor positive, HER2 negative advanced breast cancer who were previously treated with the CDK4/6 inhibitor and an aromatase inhibitor. Could you please tell us about these exciting data?
Yes, I think it is really very helpful data for us in clinical practice. As you know, alpelisib is an alpha selective PI3 kinase inhibitor that was found to improve progression-free survival in patients who had metastatic disease, hormone receptor positive, HER2 negative, progressing on or after a prior aromatase inhibitor. And in that patient population, median progression-free survival was 11 months in the alpelisib arm and 5.7 months in the group that received fulvestrant and placebo, with a hazard ratio of 0.65 and was highly significant. Of course, after SOLAR-1 had started and enrolled all of its patients, essentially, CDK4/6 inhibitors made a huge impact on our treatment of patients with hormone receptor positive metastatic breast cancer. And most patients now, based on the really impressive progression-free survival and overall survival data in some settings, receive CDK4/6 inhibitors before they would receive a PI3 kinase inhibitor. Only 20 patients in SOLAR-1 had received prior CDK4/6 inhibitor treatment. In that group, the median progression-free survival was 5.5 months in the alpelisib arm and only 1.8 months in the placebo arm. So, you know, it certainly was suggestive, but the number of patients is just too low. And so we really needed to understand the benefit of alpelisib in patients who'd received prior CDK4/6 inhibitors. So BYLieve is a phase 2 open label 3-cohort non-comparative trial. The first cohort is the cohort that I presented at ASCO 2020. These are patients whose cancers had progressed on a prior CDK4/6 inhibitor and aromatase inhibitor as their immediate prior treatment. It was called cohort A, and those patients were treated with alpelisib and fulvestrant. There was another cohort of patients who had progressed on CDK4/6 inhibitor and fulvestrant. They received alpelisib and letrozole. Those patients have not yet reached their 6-month landmark analysis for the primary endpoint. The third cohort is still accruing, and those were patients who had progressed on chemotherapy or endocrine therapy as their immediate prior treatment, but didn't have to have received a CDK4/6 inhibitor, and is more looking at a heavily pretreated population of patients. So the primary endpoint was the proportion of patients alive without progression of disease at 6 months, essentially PFS at 6 months. And then there were a number of different secondary endpoints which have been evaluated, but some of which will still need additional analysis over time. For the efficacy endpoint, the population for analysis included patients who had centrally confirmed PIK3CA mutations. So there were a few patients who didn't have central confirmation. And then overall response rate and clinical benefit rate were in the group of patients who had measurable disease. We enrolled 127 patients, and 121 had centrally confirmed PIK3CA mutations, and 100 patients had measurable disease. In terms of prior therapy, 15 patients, interestingly, had received their CDK4/6 inhibitor in the adjuvant setting, which was kind of interesting. And nobody had received prior fulvestrant. About 6% had received prior chemotherapy, and most patients had some degree of endocrine sensitivity, either secondary endocrine resistance or one patient with endocrine sensitive disease. The PFS at 6 months was 50.4%. And in order to be significant, the lower boundary of the 95% confidence interval had to be greater than 30%, and it was 41.2. So the primary endpoint was met. And 50.4% of patients is quite similar to what, in fact, a little better than in the 20% patients in SOLAR-1 in the PIK3CA mutant cohort with prior CDK4/6 inhibitor exposure who received alpelisib and fulvestrant, where 44.4% of the patients were alive without disease progression at 6 months. We looked at responses, I mentioned, and most of the responses were partial response. There were no complete responses, so 21% of patients had a partial response. The clinical benefit rate was 42%, which was quite encouraging, and in all patients with centrally confirmed PIK3CA mutations, 45.5%. And the waterfall plot, which is available on the slides on the ASCO website, is quite encouraging because it includes the patients who had any decrease in the best percent change from baseline. And in the prior CDK4/6 inhibitor and AI cohort, 70.1% of patients had a decrease, and in SOLAR-1, 75.9%. So it does seem as though we had very similar data, and it's quite encouraging. In terms of adverse events, there was no increase in toxicity in patients who had a prior CDK4/6 inhibitor. In fact, what we saw was a little bit better management of toxicity, less adverse events leading to discontinuation, better maintenance of dose intensity, and specifically for hyperglycemia, about a fifth decrease in the number of patients who discontinued therapy due to toxicity, which was quite nice, only 1.6% versus over 6% in SOLAR-1 when people just didn't have experience managing hyperglycemia. Rash has also been an issue, and similar to what we saw and have recently published in SOLAR-1, patients who received antihistamines before a rash or had no event had much decrease in their rash. I mean, the number of patients who had no rash was 70% versus the patients who didn't take preventive antihistamines, where it was 53%. And we have the rate of patients who had grade 3/4 rash. So it is very encouraging and suggests that preventive non-sedating antihistamines should be used in these patients. This is a single-arm study. So in order to try and get an idea of how this compares to other treatments that might be used, we looked at a similar group of patients, 95 patients, who had PIK3CA mutated hormone receptor positive advanced breast cancer in the US. They all had to have received prior CDK4/6 inhibitor-based therapy, and we used the US Flatiron Health Foundation Medicine Clinicogenomics database. The most common treatments that patients received, as you would expect, was capecitabine or fulvestrant, fulvestrant and palbociclib, some combination endocrine therapy as well. We looked at a number of different ways of assessing the PFS effect of alpelisib compared to the BYLieve, compared to the real-world setting group. So BYLieve compared to the real-world setting group. Unadjusted, weighting by odds, propensity score matching, or exact matching. And in all of these the standard treatment resulted in a PFS that was in about the 3.5-month range. And the BYLieve cohort had PFS ranging from 6.5 to 8 months. The exact matching was 6.5 months and propensity score matching 8 months. Even in the unadjusted results, we saw almost a double, well, essentially a doubling of the progression-free survival with alpelisib and fulvestrant. So this is actually very encouraging, I think, and allows us to do these single-arm studies in order to show benefit of a novel agent in combination with standard endocrine therapy, where we've selected the patient group based on a mutation that will make the tumors more sensitive to treatment. But because treatment changes over time, CDK4/6 inhibitors became a standard of care after SOLAR-1 had largely accrued all of its patients. We don't want to go back and redo the whole phase 3 randomized trial again. So comparing to a real-world analysis group of patients that are carefully matched allows us to show, I think, relatively clearly that alpelisib combined with fulvestrant, even after CDK4/6 inhibitor treatment, results in an improvement in progression-free survival and tolerable efficacy. And then lastly, I think that we also showed, at least suggested, because we're comparing it historically to SOLAR-1, that if you have experience in managing the toxicity with alpelisib, that you can maintain dose intensity more effectively and reduce discontinuation and dose holds from toxicity.
What a fantastic overview. Thank you so much. And congratulations. This is really some very intriguing research. And I know there's been a lot of excitement about it. I'd also really love to pick your brain on the KEYNOTE-355 trial, which is evaluating pembrolizumab and chemotherapy in patients with previously untreated, locally recurrent, inoperable, or metastatic triple-negative breast cancer. What are your thoughts on these data, and what role could you see this regimen playing in the treatment paradigm?
KEYNOTE-355 is a fascinating trial. I think it's our second trial looking at the addition in a randomized phase 3 placebo-controlled design, looking at a checkpoint inhibitor in combination with chemotherapy as opposed to checkpoint inhibitor therapy by itself, where we've seen efficacy, and that efficacy can be quite durable, but it's in really a minority of patients and mostly in the first-line setting. So this trial actually had some differences from the IMpassion130 trial. Patients were randomized to receive chemotherapy with either pembrolizumab or placebo, but the patients were allowed to be randomized on the study if they had developed recurrent disease 6 months or later, so after 6 months after their last adjuvant or neoadjuvant chemotherapy. The cutoff in IMpassion130 was 12 months. So that's an important difference because we'd like to try and treat patients who have these early relapses. The second major difference is different chemotherapy regimens. So you could use nab-paclitaxel, paclitaxel, or gemcitabine and carboplatin given on a day 1 and day 8 schedule. And that's really important because patients who relapse shortly after they've received their neoadjuvant or adjuvant taxane really don't have a potential immune therapy option because of the inclusion criteria for IMpassion130. All of these patients were treated in the first-line setting, and they stratified based on PD-L1 tumor expression using a very different test than IMpassion130, where the SP142 assay is used. For pembrolizumab, they use a scoring system called the CPS score that actually creates a ratio, and so the number is 1 or greater is positive versus less than 1. However, in a prior trial, KEYNOTE-119, which looked at single-agent pembrolizumab in the second or third-line setting versus chemotherapy, there was a suggestion that having higher rates of CPS scores would correlate with better outcome from pembrolizumab, even as a single agent. So when the data actually came out from the KEYNOTE-119 trial, This trial was amended to change the endpoint to not just be CPS of 1 or greater, but also CPS of 10 or greater as a score. So using a higher bar in order to see benefit. And I think that's really important because there was no data available to any of the people involved in the study at the time that that change was made. And it was made based on a further understanding of the importance of PD-L1 positivity and intensity based on using different antibodies and different scoring systems. So what was presented at ASCO was actually the 847 patients who were randomized 2-to-1 to receive pembro chemo versus placebo chemo, and then looking at the patients who had different CPS scores. These patients, it's interesting is figuring out how many patients had gem carbo, and as you would expect, and 55% of the patients received gem carbo. If you look at the CPS score of 1 or greater, it was about 75% of patients, and this is absolutely the same as what we saw in a retrospective analysis in Impassion 130, and have seen overall that somewhere between 75 to 80% of patients with triple negative disease have a CPS score of 1 or greater compared to 40% with SP142. Interestingly, if you looked at the group of patients who had a CPS score of 10 or greater, it was this was seen in about 37 to 39% of patients, much closer to the population we're identifying with SP142, although I have to say we don't know if it's the same group of patients, if there's complete overlap. My guess is there is probably quite a bit of overlap just based on what we know about the biology of the disease. In the group of patients who had a CPS score of 10 or greater, there was a statistically significant improvement in progression-free survival with a hazard ratio of 0.65. And if you looked at the median PFS, it was 5.6 to 9.7 months. So I think an impressive difference in progression-free survival, and the p-value of 0.0012. So this is actually really encouraging information. If you looked at the patients who had PD-L1 of CPS of 1 or greater, the original first endpoint, the difference is only 2 months, but it's still statistically significant with a p-value of 0.0014. It's just it didn't meet the actual statistical criteria for the trial. If you look overall at all of the patients, there's no difference if you include the patients who don't have PD-L1 positive disease in the mix, and that's similar to what we saw in Impassion 130. There was no other predictor specifically of benefit. It really was the CPS score that really predicted the benefit to the largest degree. And overall survival is still immature, so there isn't data on that as yet. Toxicity was very modest, and there wasn't serious immune toxicity, which was of great concern, more than what we've already seen with checkpoint inhibitors. The most common toxicity being thyroid disorders. Thankfully, pneumonitis occurred only in 2.5%, with only about 1% having anything of higher grade, grade 3 or greater, very small numbers of other toxicities. So really encouraging. And I think that what this trial tells us is that 1, PD-L1 status is really important. 2, we can combine checkpoint inhibitors with other chemotherapeutic agents. And this is really important because I think that we can also use this data in the post-neoadjuvant setting, potentially in patients with poor responses, and certainly in patients who have metastatic disease who've already received a prior taxane. We have a new option for therapy.
Thank you. That was, again, a really great overview of a very interesting trial in triple-negative breast cancer. Now, in HER2-positive breast cancer, we're seeing the Phoebe trial, which is looking at pyrotinib or lapatinib plus capecitabine for HER2-positive metastatic breast cancer. Can you discuss this agent a little bit and how it could impact the management of these patients?
Yes, this is an interesting study conducted in China. Pyrotinib was developed in China, and it's used now in China based on positive data from other trials looking at the activity of pyrotinib, which is a potent oral tyrosine kinase inhibitor that has both activity for HER2 and HER1 or EGFR. So what they did was a phase 3 trial trying to see whether or not pyrotinib would be better than lapatinib with capecitabine. And actually, I think it's a really interesting question because you're really comparing apples to apples here. So it's similar to the NALA trial that looked at neratinib versus lapatinib with, or in combination with capecitabine in pretreated patients as well. So I think important in terms of trying to assess whether an oral tyrosine kinase inhibitor is better than another oral tyrosine kinase inhibitor. What they did was took patients who could have received 2 prior lines of chemotherapy and randomized them to receive the pyrotinib or lapatinib continuously plus capecitabine at the dose we're most comfortable with, 1,000 milligrams per meter squared, 2 weeks on, 1 week off. They randomized 267 patients. And I think that one thing that's important to keep in mind in this trial is that some of the patients would not have necessarily had resistance to trastuzumab. Very few, if any, would have received pertuzumab or TDM1, trastuzumab emtansine, simply because of availability in China. However, they were able to look in their data at a subset of patients who had trastuzumab resistance. What they saw was, interestingly, the PFS was 12.5 months with pyrotinib and capecitabine versus 6.8 months with lapatinib and capecitabine. And that met their criteria for being statistically significant with a p-value less than 0.0066. They looked at trastuzumab resistant patients and saw a PFS of 12.5 months versus 6.9 months with a hazard ratio of 0.6. They saw benefits in objective response rate and duration of response. Pyrotinib is a very potent oral tyrosine kinase inhibitor, so it causes a lot of diarrhea, and grade 3 or greater diarrhea was seen in 30.6% versus 8.3%. There was no difference in hand-foot syndrome. So the meaning of this is that actually we can see differences in these oral tyrosine kinase inhibitors that target HER2 and EGFR. In some ways, until we've gotten to tucatinib, the rate of diarrhea correlated with the potency of these drugs in metastatic HER2-positive breast cancer. Because the patient population is less heavily pretreated than in a population treated in the US and Europe, where the drugs are more available, or in some other places in Asia, we don't know how pyrotinib will, for example, measure up to, say, tucatinib, which causes less grade 3 diarrhea with capecitabine, about 13% versus 30%, and seems to have significant activity in the brain as presented by Nancy Lin at ASCO this year, and we'll talk about in just a moment. So for me, this is really important in the Chinese population because you have a very active agent that's available and affordable to patients where they have had poor access to many of the more expensive HER2-targeted therapies. Where it goes in terms of the world, in terms of being used in pyrotinib, it's another option, and we'll have to see how it, again, measures up to some of the newer therapies that have been approved.
Wonderful. And as you alluded to with tucatinib, that's an agent that was obviously recently approved in combination with trastuzumab and capecitabine as a treatment for patients with unresectable, locally advanced or metastatic HER2-positive disease, including those with brain metastases following at least one prior anti-HER2-based regimen in the metastatic setting. We're getting more HER2 climb data at this year's ASCO. So what is important to note about these newer data?
Well, we were really excited after the HER2 climb data was presented and published on the same day at San Antonio. And of course, excited when the FDA approved tucatinib in combination with capecitabine and trastuzumab with very broad eligibility relatively. But I think the most exciting part about all of this data, besides the improvement in survival, and that was in some ways even more impressive than the PFS difference, was the impact in patients who had prior brain metastases. In the original phase 1 expansions of tucatinib in this triplet combination, there had been really impressive activity shown in patients who had active or previously treated brain metastases. So when this trial was designed, they actually allowed patients who had brain metastases to enter in, and there were 3 different groups. Just to remind everyone, it's a 2-to-1 randomization of tucatinib or placebo with a backbone of trastuzumab and capecitabine, again using that 1,000 milligram per meter squared of capecitabine. So you could have had brain metastases that had been treated and were stable, or you could have had asymptomatic brain metastases. And so there were two different, essentially, groups. So out of the 291 patients with brain mets, 174 had active brain mets, which is pretty amazing. 66 of those were untreated, and 108 had been treated but had progression that didn't need emergent treatment with, say, some radiation technique. 117, a smaller number, had treated stable brain metastases in this group of patients. And what they have reported here, which I think is really interesting, and remember, this group of patients, 70% had received prior radiation therapy, and whole brain radiation had been received in somewhere between, somewhere around 42% of patients. So the progression-free survival benefit in terms of the CNS was really quite dramatic. A median CNS progression-free survival in this group of patients was 4.2 months with placebo and 9.9 months, more than a twofold improvement in patients receiving tucatinib with a hazard ratio of 0.32, enormously statistically significant, just really impressive. But in addition to that, which I think is the most important data coming out of ASCO, is that there was an overall survival benefit in patients with brain mets, improving by almost 50%. So 12 months to 18.1 months, hazard ratio of 0.58. Really impressive data. They looked at the group of patients who had active brain metastases, either treated or not previously treated. These patients also had a dramatic difference. Hazard ratio of 0.36, same kind of benefit, 4.1 versus 9.5 months. And the overall survival benefit was, if anything, even more impressive, 11.6 to 20.7 months in these patients with active brain metastases. And of course, that interestingly, it's kind of interesting to what we do in the future, patients who had stable brain mets had, if anything, a bigger benefit. They went from the PFS of 5.6 to 13.9 months, which is, a 70% relative improvement, which is unbelievable and hasn't ever been seen before. The survival benefit was also impressive, a little bit smaller, but it's a smaller group of patients, and presumably they'll have to be followed over time, where the hazard ratio is 0.88, and there was no significant difference there, although relative decrease. So I think, they saw responses in brain as well, but I don't think that's really the key part here in looking at this. It's really the amazing results of tucatinib. They had one other analysis, which is like PFS2, what we've seen with CDK4/6 inhibitors. They looked at patients who had progressed in brain, and then they continued on treatment. So they could get radiation and continue on study treatment. And if you looked at that group of patients, the median time from the first CNS progression to the second progression or death was also more than doubled, 3.1 versus 7.6 months. That means you had progression in brain, you got radiation, you continued on tucatinib, trastuzumab, and capecitabine versus placebo. You did dramatically better if you received tucatinib, hazard ratio of 0.33, really quite impressive. So, that we know the toxicity, there's some grade 3 diarrhea, but it's generally manageable. This, doubling the intracranial response rate is great, but I think what's most impressive for our patients is this dramatic improvement in progression-free survival and overall survival, and the data on continuing treatment after modest progression, where you don't need to have a big change in treatment. And they actually have published this data as of today in the Journal of Clinical Oncology. So on the day that ASCO opens, they had a publication, which is wonderful.
This is some really, really great insight. I'm really excited to be hearing more about HER2CLIMB, so thank you so much. Now, you're also the author on a phase 1b study of abemaciclib in combination with pembrolizumab for patients with hormone receptor positive, HER2 negative, locally advanced metastatic breast cancer. So would you like to highlight these interim results?
Yes, I think this is an interesting trial. So there's been a lot of preclinical data, which is quite encouraging and suggests that if you give a CDK4/6 inhibitor, you can enhance the efficacy of PD-L1 or PD-1 inhibition. These preclinical studies were largely done with abemaciclib, and abemaciclib is a very potent CDK4/6 inhibitor. So this trial, JUPCE, was designed where there were two cohorts, essentially, and each of those two cohorts were broken down into two different groups. So one is non-small cell lung cancer that I won't talk about. The second is hormone receptor positive metastatic breast cancer. We had two cohorts in the breast cancer group. Cohort C, that was the subject of the ASCO presentation and update, still interim analysis of this group, These patients received abemaciclib and pembrolizumab and had received 1 to 2 prior chemotherapy regimens for advanced disease and had measurable disease. The second cohort in breast cancer that was presented at AACR's virtual meeting this year were patients who had received prior endocrine therapy and in the adjuvant setting, so they could have been treated in the first-line setting, and they received abemaciclib, pembrolizumab, and anastrozole, the triplet combination. In this cohort C, where patients received the doublet, we previously presented data, but this is a longer term evaluation of efficacy. And what we saw was a partial response in 8 patients, or 29%, higher than what we would have expected to have seen based on the data from Monarch 1. In Monarch 1, patients were treated who had a similar prior exposure to chemotherapy, so 1 to 2 prior lines of chemotherapy, and were given single agent abemaciclib. And the response rate was about 19%, but that led to approval of single agent abemaciclib. Now that we have all these other data in combination with endocrine therapy, it's not used as a single agent, I don't think, much in clinical practice. But this data was quite comparable and showed the suggestion of an improvement potentially over single agent abemaciclib. So we were encouraged by this. The overall response rate comparing to we also looked at comparing PD-L1 status, thinking that based on the data from pembrolizumab and atezolizumab, that PD-L1 status would make a difference. But here we used 22C3, the assay that is a CPS scoring, and looked at 1% or greater. And that just may not be a high enough number in order to see differential benefit. Maybe you need to be using this higher CPS score like was used successfully in Keynote 355. But in any case, using that cutoff of 1% or greater using 22C3, the PD-L1 positive and negative groups were split down the middle, and there was no difference in overall response rate or clinical benefit rate. The median progression-free survival in these patients was actually quite impressive at 8.9 months. It didn't differ based on PD-L1 positivity or negativity, and median overall survival also was similar, 26 months in the overall population, and a tiny numerical difference, not at all significant based on PD-L1 status. So we looked at safety as well, and it's actually quite interesting that the increase in transaminases was a little more prominent with this doublet combination. So 9 patients, or 32%, and 7 patients, or 25%, had all grade elevation in transaminases, and 18 or 11% for AST and ALT had grade 3 or greater elevations. And that's more than we would expect, certainly using single agent abemaciclib or abemaciclib combined with endocrine therapy, as is currently used. In this particular trial, we also saw diarrhea of grade 3 or greater in 11% or 3 patients, and 80% of patients, as you would expect, had all grade diarrhea, because we see this with abemaciclib to some degree. Maybe it's a little bit higher, but it's not clear. We didn't see a lot of significant interstitial lung disease. 1 patient had grade 3 or greater dyspnea, but other than that, there were some patients, who had grade 1 and 2, but 8 patients out of the total cohort of 28. If you look at the number of the percentage of patients who reported ILD or pneumonitis, all grade was 4 patients, or 14%, and 1 patient, or 4%, had grade 3 or greater. And presumably this fits in with the report of dyspnea, because that patient would certainly have been short of breath in the grade 3 or greater setting. But that in and of itself wasn't considered to be too concerning. However, in cohort D, as I mentioned, the triplet combination that was presented at AACR, we saw a relatively more significant pneumonitis and liver enzyme elevations. In particular, the pneumonitis, so we had a couple of patients who had pulmonary embolisms and complicated breast cancer situations who actually died, and they couldn't rule out a role of interstitial pneumonitis, ILD, as a cause. And based on the benefit risk assessment of these combined cohorts, we felt that it did not support further development of abemaciclib with pembrolizumab, with or without endocrine therapy in metastatic disease. However, the preclinical data is quite interesting and I think encouraging. So there are a number of other studies looking at different agents and different combinations. And I think it will be, this is a small group of patients. It's just about 60 patients altogether in the two cohorts combined. And potentially we need to learn to identify what's going on with these patients earlier and better understand how to intervene. So the ongoing trials that are evaluating this idea based on the preclinical murine data will be very helpful to understand whether or not adding a CDK4/6 inhibitor to a checkpoint inhibitor with or without endocrine therapy promotes immune-related toxicity.
Very, very great overview. Thank you so much. And just in closing, looking at, obviously there's so much breast cancer abstracts presented this weekend. Is there any other data that you wanted to highlight?
There is quite a lot of really interesting data that's been presented. I think the alternate trial was very interesting, not showing that any difference in neoadjuvant therapy, whether you gave fulvestrant combined with anastrozole or fulvestrant alone or anastrozole alone, and will give us a lot of, I think, preclinical data, translational data, it's not preclinical, it's clinical, but on different biomarkers to look at in these patient population, which I think will be really helpful. There was some other interesting data looking at veliparib with cisplatin, primarily benefit in patients who have BRCA mutations, but also the suggestion of benefit in patients who have somatic acquired mutations. And then a fascinating study through our consortium presented by Nadine Tung looking at olaparib, the PARP inhibitor in patients who had alternate DNA damaging mutations, showing a benefit in patients who have germline PALB2 mutations, as well as patients who potentially, small numbers, who had somatic mutations in BRCA1 and 2. So I think that those data, which we'll hear more about, I think, in the future as the trial expands, are really important. There's been some question about whether or not we should be using fulvestrant instead of an AI in first-line setting based on prior data from the Falcon trial, but in a group of patients who didn't have any prior endocrine therapy in any setting. The Parsifal trial actually was a phase 2 randomized open label trial. Patients received fulvestrant or an AI with the CDK4/6 inhibitor palbociclib, and there was no difference in outcome. So I think that that's very encouraging and definitely suggests that you can use the hormone therapy that works the best in that situation, keeping in mind what you're going to be seeing, what you're going to want to treat patients with afterwards. There was also some interesting data with the androgen receptor agent, targeted agent bicalutamide in combination with palbociclib in the treatment of patients who had AR positive metastatic breast cancer. And I think this is of interest as we now have patients with hormone receptor positive disease who've received, a number of lines of therapy, as well as patients with triple negative disease. This trial focused on patients with AR positive triple negative breast cancer with the idea that you might be able to improve the effectiveness of androgen blockade by using a CDK4/6 inhibitor in triple negative breast cancer. They only have 33 patients for the abstract, and you can't see the presentations as of today, and it was a single arm, but they did see 11 patients who were progression-free at 6 months, which seems good. I mean, it's important to keep in mind that AR positive triple negative breast cancer has a better natural history, but still, I think this is really encouraging and probably the first encouraging data we've seen with targeting AR in triple negative breast cancer in some time. So I think that I'm excited to see how that trial continues to show data. There's some data also that talked about ctDNA, which I think is really useful in patients in the metastatic setting. There was biomarker data from the Catherine trial looking at TDM1 in patients with residual disease after neoadjuvant therapy versus continued trastuzumab. We already know that trial showed dramatic benefit from switching to TDM1, but this was a biomarker study that showed no difference in patients who had PIK3CA mutations. They all benefited, which is great. But interestingly, there were some patients who had a high expression of HER2 versus low. And the patients with high expression of HER2, they benefited from TDM1, but they did not benefit from trastuzumab. So that's actually really helpful data. They also looked at PD-L1 as well. And I think that these kinds of data sets give us even a better idea of who needs to specific change of therapy in order to benefit patients. You know, the other things that I think are of interest, the long-term results of MINDAC, more results about younger patients, and potentially benefit from ovarian suppression in the high clinical risk, low genomic risk group of patients. Worthwhile looking at that data in more detail. And then some data about the updated data from TRAIN-2 that looked at anthracyclines or not as neoadjuvant therapy for HER2-positive breast cancer, and suggested that there's more toxicity with anthracyclines and equivalent outcome in patients who received a non-anthracycline-based chemotherapy regimen.
Dr. Rugo, thank you so much. You gave so much great insight on tons of different studies that are being presented this weekend. So I really appreciate your time, and I hope you enjoy the rest of your ASCO weekend.
Thank you. I will say to people, if you haven't yet seen the plenary data, there is a breast cancer abstract in the plenary session that will be looking at patients who had surgery with essentially de novo metastatic disease versus not. And I encourage you to look at that data. It will be very interesting.
Wonderful. Thank you, Dr. Rugo.
Thank you.
Taking the time.
Take care. Bye-bye.
That's all for today. Stay tuned for tomorrow's OncLive News Network on location at the 2020 ASCO Virtual Scientific Program, where we will sit down with Dr. Roy Herbst on his take on the most significant studies in lung cancer, as well as Dr. Brian Reaney and Dr. Christopher Sweeney on the biggest news happening in genitourinary cancers. Thank you for watching OncLive News Network. I'm Gina Columbus.